So I'm talking about the meniscus root tear. It's a big issue for the meniscus root tear because it's for me it's the most difficult meniscus repair and it's not straightforward. So looking at the anatomy of the meniscus, right? So the medial side, lateral side is not the same, and the most common problem is the root. Okay, the medial side is more attached comparing to the lateral side. So the meniscus function root is quite important. Is the convert the axial loading to the hoop stress. So biomechanical study by Robert, he found that the posterior root meniscus is compatible to total meniscectomy. So the lateral root and medial root is not the same. So the medial side is more common in the middle age. Minor injury like twisting, squatting, radial tear close to the root attachment. For the lateral side, it's more common in the young. Traumatic injury like twisting injury and always combined with the ACL injury. So this clinical presentation, the patient always have joint line pain is more close to the posterior and more pain when the patient do deep flexion. McMillan test may be positive, joint line tenderness. For the lateral side, you may have the severe pivot shift test positive. These are the risk factors for the meniscus root tear, the Wallace malalignment, older age, increased BMI, female sex, and increased KL grading. So this is a classic MRI from the meniscus root. Number one, you can see the meniscus extrusion on the medial side and ghost side, okay, cleft side, and you can see the myeloedema on the tibia. Classification from Labrad. Most common type is the type 2. Okay, this is the torn complete radial tear within 9 millimeters from the attachment. So this is a natural history of the meniscus root. You can see that the patient may have the root tear and followed by the detach or extrusion of the meniscus. Okay, after that, the outer the knee kinetics. Meniscus extrusion can create a progressive joint narrowing or cartilage degeneration. And finally, the patient will have osteoarthritis of the knee joint. The association between the root and the osteonecrosis, okay, is up to 80%. So this is one of my patients. She had root tear, but we treat her conservatively. She denied the surgery. 2 years after that, the patient have osteonecrosis of the medial femoral condyle. So it has a very high correlation. So when we're treating the root, we should look for the cartilage and the alignment also, not just the soft tissue, and also the ligament of the knee. And this is the algorithm of the meniscus root tear. So try to repair the acute root tear as soon as possible before arthritic change. If you repair it too late, it's too late to repair. Repairing alone may not work. You need additional surgery like axis correction, STO extrusion reduction, or root reconstruction. So repair it as soon as possible. So this is my position of the meniscus root repair. I break the table and drop the leg down like that. The goal is to prevent the arthritic change. Indication is acute or chronic tear without osteoarthritis, KL less than 2. So this is a good candidate for the root repair acute injury, joint space narrowing, extrusion less than 3 millimeters. Contraindication in the patient have subchondral bone collapse, substantial malalignment more than 5 degrees, BMI more than 30. So this is a bad candidate for the meniscus root repair. Injury, joint space narrowing, large gap, extrusion more than 3 millimeters. This is too late to repair it alone. So how to repair it? You need to consider 3 factors: the techniques, suture, construct, and extrusion reduction. So there's 2 common techniques, the transtibial pull-out technique and the suture anchor techniques. So I'm talking about the transtibial technique first. So this is my technique proposed in the arthroscopy techniques. This is good for the patient have the minimal gap. You can make a transtibial tunnel suturing technique using the spinal needle and then you can tie the meniscus to the post. Two tunnel techniques, the benefit is that you can increase the contact area, right? Like this patient, he's an orthopedic doctor. I did the two tunnel techniques for him. Actually, he requests for that, and we use the tape, okay? And you can do like a suture bridge fixation like this and do the suture to the post. Yes. So this systematic review found that the result of the root repair complete healing is around 60 to 90%, but the extrusion reduction is only 50%. That's the problem. We can reduce the extrusion only 50%. This is another article from Dr. Somsak from Thailand. He proposed the soft anchor for suture fixation. For the exposure, I think it's quite important when you're doing the root repair. So the medial opening of precasting is quite important. I propose the technique we call the magic point. So this magic point is quite important. You can do the release. So you look at the video. We draw the line from the posterior tibia. Okay, intersection with the joint is about 1.2 centimeters from the joint line. Okay. And then you use the needle number 18. So if you touch the right point, it will open suddenly and you can hear the pop sound. Okay, this is the my articles about the magic point. So this is another technique. We use the suture anchor. And nowadays, I think I prefer using suture anchor instead of the transtibial, because we found that many patients that I do the transtibial that's cut through the meniscus, and because I think the length from the fixation to the repair site is too long, you may have the Bancha effect. Okay. Nowadays, I changed my transtibial to this technique. This is a suture anchor. It's very simple. You make a transtibial first, and then you can use the soft anchor like Q-fix or why not. Okay, and then you can drag the anchor into the joint. I use a mid-medial portal. Okay, when you drag the anchor in, then when you pull it out, it's like a ball. Okay, underneath the subchondral bone. Yeah, and your fixation point is very close to the tear site. So I found better result after using this technique. You have less Bancha effect. Okay. So from the study, they found that the suture anchor have better biomechanical properties, but the suture construct is still controversy. So this is articles they propose that the double locking loop is the best loop, yeah, and have better biomechanical properties. The simple cinch also not too bad. From this article, it's easy, simple, single pass high load to failure. I propose extrusion reduction because 50% of my root repair, the meniscus cannot reduce. Even the meniscus good healing, but extrusion is still persist. So the extrusion reduction is good to reduce the tension, strength, and shock absorption, and also the preventing the progression of osteoarthritis. So from this article, they found that if you have the good extrusion reduction, the patient will have the better reach home score, IKDC score, and KL arthritic progression after the surgery. Okay, so I show you the techniques. This is very simple. You make a mid-medial portal. Okay, so pass the suture into the meniscocapsular junction and tie the knot, so you can reduce the extrusion of the meniscus. Comparing before and after the extrusion reduction, you can see that the meniscus can cover the tibial palatal better. Okay, comparing to the before and after surgery. For the STO, I think sometimes you need it. I prefer the one leg standing view for the patient have meniscus root tear, because sometimes two leg standing view it's not represent the true axis of the patients, because if the patient have pain, they will not put the weight on the side that have pain. So we found that if you put one leg standing view, you can see better axis of the patient. Okay, like this patient have the good alignment, but when you do one leg standing view, is more joint space is narrow comparing to the other side. So in this situation, I will do not just a root repair, I need to do axis deviation if the patient have joint space narrow and also there's some cartilage damage. Okay, I start my root repair first using the transtibial. Okay, and then we do HTO after that. I protect the suture using the metal rod. Okay, then I do HTO, and it's safe because you protect your suture all the time during your HTO surgery. Okay, and then you tie the knot over the post after surgery. Okay, this is another patient. She also have the meniscus tear, but X-ray look normal. Okay, we do HTO for her, and also we do root repair and HTO at the same time. Okay, so you see that this kind of patient always have the cartilage damage on the medial side. Just root repair alone is not enough whenever the patient start to have joint space narrow and come to you, see you very late. Okay, so we did the same way, protect the suture with the metal rod. Okay, and tie it to the post. But nowadays, I change this technique. I use the suture anchor for the HTO. Okay, like this. So this is post-op 3 months. She's really happy after the surgery. Okay, so it's still no clear evidence of the need of root repair during HTO or not, because from this study they found that you do the root repair or without root repair with HTO, it's the same. Okay. The last option is the root reconstruction that's proposed by Dr. Kim from Korea. They found that in the chronic case with big gap, so using the suture repair sometimes it's not reliable. Okay, like these patients, okay, has a chronic tear and meniscus root. So using the gasless graft, that will be the soft tissue bridge between the meniscus. So this is good for the patient have chronic tear with a very big gap. Okay, and you can fix it with the bioabsorbable screw. So this is an MRI after the surgery. You can see that it's heals nicely after the surgery. And we are very delay rehabilitation for the meniscus root tear. Okay, so take home message for the meniscus root tear, you need to consider not just the soft tissue, not just the root. You try to repair the root as soon as possible. But if you're delay or your chronic case, you need to consider about the cartilage and also the axis of the knee. Okay, so just root repair is not enough. In this situation, you may need HTO, or if it's very severe or chronic, you need arthroplasty to solve the problem. So she's my mother. In the middle, she's my mother. You look at the right knee. She has so much pain on her right knee 3 years ago. Okay, and I treat her conservatively. She cannot get into the MRI because she has claustrophobia. 3 years later, the right side with meniscus root tear, the joint space is gone, it's bone on bone. But on the left side is still the same. You see the X-ray. So I missed meniscus root tear from my mother, and finally she need arthroplasty. Root tear is important. Okay, try to fix it as soon as possible. Okay, because root tear is same like total meniscectomy. Surgical option is depend on the chronicity of the injury, knee alignment, and the presence of arthritic change or not. Okay, I prefer the suture anchor for the root repair, and I prefer to reduce extrusion. It is too much, and this axis deviation, we need to do additional surgery like HTO. Okay, thank you.